I'm an academic GP at the Department of General Practice at the University of Melbourne. And it's great to have a focus today on what's happening in the primary care space in terms of antimicrobial stewardship. We've got two international visitors today, Karen and Noah, both from Toronto, who will be providing different perspectives of some of the different stewardship programs that are happening in Canada. And my son may also be putting in some bonus YouTube videos, so apologies in advance if that happens, and inevitably it will. Karen is a professor in the Department of Family and Community Medicine at the University of Toronto, and she's got an interest in particular in primary care, electronic medical record data. So Karen, can I get you to come up and share this with us?
Thank you, Joanne. I'm very excited to be here in Melbourne. This is my first time in Melbourne. I'm loving the weather. We have snow in Toronto already in mid-November. There's snow on the ground. So I'm going to talk to you about studying antimicrobial stewardship using big data in Ontario, Canada. So just about some of the data sources available to study antimicrobials in Ontario. We have administrative data, which is the Ontario Drug Benefit Database, otherwise known as ODB. It's great, it's excellent, it's province-wide. It's the pharmacy dispense data in all the pharmacies in Ontario. It has the drugs regardless of the type of prescriber, and we can actually link it to who the actual prescriber is. It's very well organized. It has days supply. They're all attached to these DIN numbers, which can tell us the exact medication that was prescribed, and it has the actual cost that of the drug. It's a great comprehensive database. The only problem is it's limited to patients age 65 and over that are covered by the Ontario Drug Benefit Database. And there are some people on social assistance that it covers. And more recently, about 2 years ago, the government brought in for coverage for children, which I thought was going to be fantastic. But then within 6 months to a year, we got a new government, and then they changed that whole program. So now there's some coverage, but if you have a drug plan, you're not covered. So it's not comprehensive for children anymore. But it is very comprehensive for those age 65 and over. And then we have this derived pharmacy dispense data called IQVIA. I don't know if you have similar database in Australia. I think it is, they have these databases around the world. It's definitely in the United States. They have this exponent database that carries the physician characteristics of the prescribers. It's province-wide. There's regional representation. It includes prescriptions for all ages. But it's derived from 65% of the outpatient pharmacies in Ontario, and they link it to insurance claims to try to identify indication for medications, and they link it to sales data to try to estimate what the prescribing is for a whole population. So it's pretty good. It gets all ages, but you can't do anything at an individual level because it's all derived. And then there's primary care EMR data, namely from the EMERALD database, which stands for Electronic Medical Record Administrative Data Linked Database. It's a database I developed about a decade ago. It includes primary family physician EMR data. It includes prescriptions for patients of all ages. It reflects the actual family practice prescribing practices. The indications are documented. But it's only a convenient sample of family physicians. There's only about 2% of family physicians in Ontario that contribute to the data, and tends to be limited to the family physician prescriptions and relies on the family physician to input the prescriptions from other providers, like from the specialists or other family doctors. And it requires that, so it's very populated for the other prescriptions. And the indications are there, but they tend to be buried in the free text data, which requires extra data mining methods to identify. So I have to give credit to Dr. Kevin Schwartz, who I'm going to present a lot of his work. He is the PI on a grant called the Ontario Program to Improve Antimicrobial Use, OPTIMIZE. Kevin Schwartz is an infectious disease specialist and a public health physician, and it was kind of his brainchild to start studying antimicrobials in Ontario. So we did a database that compared the prescribing data in the electronic medical record to that's contained in the administrative data. So this was confined to patients that were 65 and over, and the top line is all the antibiotics prescribed by any prescriber, and then the bottom two lines are those. The circle line is for those prescriptions by Emerald physicians, the family doctor. So as you can see, only 26% of the antimicrobials that patients were receiving were actually captured in the EMR data compared to the pharmacy dispense data of the Ontario Drug Benefit Plan. And of the ones that were prescribed, 80 that were dispensed in the pharmacy for the prescriptions by the Emerald physicians, 85% of them actually showed up as a prescription in the EMR. So there is a bit of a discrepancy there. 25% 15% are discrepant. Reasons for discrepancy could be that the EMR physician called in the prescription, didn't document it in the EMR, or he wrote it on a paper prescription and didn't document it in the EMR. The other sources of discrepancy is if they prescribed it, but the patient didn't actually go to the pharmacy and get it filled. But this showed us that EMR data is not appropriate for assessing antimicrobials in the whole population, but it would be very reasonable to study at the physician level of what the family doctors are doing in terms of antimicrobial prescribing. And then we looked at predictors and variability of antibiotic prescribing amongst family physicians. So he looked at patient characteristics, physician characteristics, and clinic characteristics. And he found that age and sex led to more antimicrobial prescribing. Patients aged 3 to 5 years that were female had the highest rates of antimicrobial prescribing. Being in higher income quintiles had slightly higher antimicrobial prescribing as well. In terms of physician factors, years since graduation and gender didn't make a difference, and medical school of graduation didn't really make a difference, but the only physician factor that made a difference was the median daily visits. So patients or physicians that had a lot of visits tended to prescribe more antibiotics. And we did find there was large regional variation in terms of rates of antimicrobial prescribing. And this is just showing you, he ranked the physicians from 0 to 100 in terms of odds of prescribing an antibiotic. So the green dots are that. And then he adjusted for patient characteristics. And we have found that very few actually made very little difference in terms of antibiotic prescribing when we added in patient factors. The yellow dots are those that had more than 10% difference in changing where they might lie in terms of rates of antimicrobial prescribing. So this just tells us that really it's physician factors more than patient factors that lead to high rates of antimicrobial prescribing. And then he looked at the regional variation with the ICVIA database, the derived database, and then he was able to look at the whole province of Ontario. And this is just showing you age and sex distribution of antimicrobial prescribing. Women aged 65 years and older had the highest rates of antimicrobial prescribing, and the different colors of the bar show the differences, the types of antibiotics that were prescribed. And this is just a map of Ontario. Toronto is, this is Lake Ontario here. Toronto sits here. There's kind of a suburb of Toronto called Mississauga, which had very high rates of prescribing. And then over here in Erie, St. Clair, Western Ontario had high rates of prescribing as well. And this is just showing you just ranked by region in terms of rates of prescribing, again, with the types of antimicrobials that were prescribed. And then he looked further. He wanted to see what are those physician factors that lead to the duration of course of antibiotics. So he said that he grouped the antibiotic duration into those prescriptions that were less than 8 days and those that were greater than 8 days. And then so in a 1-year period from March 2016 to April 2017, he found that 5.6 million antibiotics were prescribed by the 10,000 plus family physicians in the province of Ontario. And of those prescriptions, 35% were for greater than 8 days. And then he looked at different physician factors, and the most significant factor was later stage in the career. So early career physicians had more short duration antibiotics compared to mid-career, compared to late career physicians that had more prescriptions for longer duration. And this is just, he did a sensitivity analysis for indication, and he just looked at the antibiotics that were for respiratory conditions and antibiotics that were for urinary tract infections. And he plotted them against each other. And as you can see, regardless of the indication, it was the blue late career physicians that had longer antibiotic prescriptions. So then we wanted to look at appropriateness of prescribing. So we did a Delphi panel to kind of decide what appropriate rate of prescribing might be. We looked at 23 conditions. All the panel members were sent an email with all the 23 conditions, the background literature on whether rates of bacterial versus viral infections. The panel was made up of family physicians, infectious disease specialists, and pharmacists. So after we each rated the percentage of visits that for a particular condition that should end up in an antibiotic prescription, we had 2 face-to-face meetings, and we went through all the different indications. We threw at the ones that there was 100% consensus, so we didn't discuss those. And this is just showing you the 23 conditions where the appropriateness benchmark was going to be. So there's over here is the 0 that antibiotics are not indicated, and over here is where antibiotics are indicated 100% of the time, and then the conditions where it's somewhere in between. And then this is just an example of 2 of the conditions for acute otitis media. On the first round, there was great spread amongst the physicians. And then after subsequent rounds, we came down to a consensus. Some of the other conditions didn't require as many rounds of discussion or voting to get to consensus. And then we took those appropriateness, the rates of appropriateness of antibiotic prescribing, and applied it to the EMR data. And this is just showing you in the teal bars the encounters with necessary or no antibiotics, and the orange is encounters with unnecessary antibiotics. And we found that potentially 15% of all antibiotic prescriptions were potentially unnecessary. And then this is just showing you of all the antibiotic prescriptions, the different colors are for ages, what percentage of them were for the different tiers of prescribing. So tier 1 were for 100% of the time they are recommended to have an antibiotic prescribed. Tier 2A was from 50 to 99% of the time they should have an antibiotic prescribed. Tier 2B was from 20% to 50% of the time they should have an antibiotic prescribed. Tier 2C was for antibiotics were indicated in less than 20% of the time. Tier 3 were for conditions where antibiotics were not indicated. And so that's just kind of an overview picture of what we were able to look at in Ontario in terms of antimicrobial prescribing. And then I think I'm going to pass it over to Noah, who will talk about interventions.
So while we get that organised and switched over, is there any questions for Karen? Is that okay, Karen?
Yeah.
About primary care data
Thanks,
and how it's used and analysed and things like that.